Welcome, everyone. We are excited to have you share some of your time today as we move through the next session of our Rural Nursing Innovation Series. Before we get started, just a brief housekeeping note that we do have two sessions today. Our first session will conclude around 3:30 Central Time, and then we will roll into the following session. We will be able to take Q&A throughout on your chat or your Q&A panel on Zoom. Just note we will hold that till the end of the first session, and then we will open up Q&A for that before we move into the second session. So feel free to use it at any time so you don't forget your questions, but just know we're going to be holding on to them. And now it is my pleasure to introduce you to our presenters today. Elizabeth Crooks is an assistant professor at the University of Alabama at Birmingham School of Nursing with a teaching focus in community health and systems leadership. Dr. Crooks is recognized for her creative teaching strategies and expertise in curricular development. Her success in developing strong community partnerships has led to an award-winning rural health experience that engages her undergraduate students with challenges and rewards of nursing practice in the Deep South. Dr. Erica Newfield is also an assistant professor at the University of Alabama at Birmingham School of Nursing, where she teaches public health nursing didactic courses and co-coordinates the community health clinic experience for undergraduate and pre-licensure students. Prior to this teaching role, she served for 10 years as a clinical service manager of the New Mexico Department of Health's Breast and Cervical Cancer Early Detection Program, and for 4 years as a public nurse in Taos, New Mexico. She earned her Doctor of Nursing Practice degree with a focus in nurse executive organizational leadership from the University of New Mexico in 2020, a Master's of Science in Nursing from Emory University in 2012, with a focus in public health nursing leadership, and a Bachelor's of Science in Nursing from the West Virginia University in 2006. Now, I would like to turn this over to our presenters. Welcome. Thank you so much for joining us today.
Thank you. I'm going to go ahead and share my screen here. So hello, Eric and I are delighted to be here with you, and we want to share with you a nursing education initiative that we have developed to support rural nursing workforce recruitment in the American Deep South. We have no relevant commercial interests to disclose. We are receiving a small honorarium for our time with you. So for those who may not be familiar with the United States, the Deep South is located in the southeastern portion of the continent, of the North American continent, and it is its own unique geographic and cultural area. It includes coastal areas, coastal plains, pine forests, and it also includes the southern portion of our Appalachian Mountains. Deep South has a legacy of agriculture, primarily growing cotton, although that is no longer our primary crop. It also has a legacy of being developed in the 1700s through the 1800s with the labor of enslaved Americans whose roots are in Africa. And so we still have some of that cultural identity. We have our own cultural cuisine influenced by that. We have our own type of music influenced by that. And we also happen to be the poorest state in the United States. This group of states are poorer than the rest of the country, and we have poorer educational and health outcomes. So when we look at contributions to the nurse workforce, the Deep South experiences a serious shortage of nurses. The most current data has the states that are along the eastern seaboard area with greater than 20% deficit in the number of nurses that they need. Alabama, you can see in the green, which happens to be where I am from, we are a nurse-producing state. So we're calculated as having a surplus. but that surplus is not distributed evenly across the state. And so our rural areas remain underserved by professional nurses. So why are we facing a rural nursing workforce shortage? Well, too few in and too many out. I know that that sounds very simplistic, but that really is the case. And the reason we have inadequate input is for a number of reasons. One is that in order to attend nursing training or nursing school, the residents in rural areas usually have to relocate for a period of time to do that. There's very limited nursing education that is actually in our rural communities, and that increases the cost of obtaining that education. The other is pay for practice in rural areas is lower than what you are paid to practice in urban and suburban areas. And so the return on that investment of leaving to get a degree and coming back and earning less, that return on investment is not as great than if they had stayed in suburban or urban communities. And then once in a rural area, there are fewer health organizations, fewer places to be, and that means there are fewer options for career advancement, which many people don't find to be attractive. On the excessive outflow, nurses in the United States are aging out and retiring all over, not just in the Deep South, but in the Deep South, the average age for a registered nurse is 48 years. Since the pandemic, we've had people leave the workforce due to increased workload, and those retirement also means that you have fewer people to share the workload. So between the pandemic and losing people to retirement, people are just leaving their roles out of burnout and dissatisfaction, something we are trying very hard to address here in the United States. And then population is migrating out of rural areas anyway. And so if a family leaves the rural area, they very often will take with them somebody who happens to be a registered nurse. And in the end, we end up with a deficit in the workforce, a significant deficit. So our initiative has two primary aims: to introduce the BSN students to the rewards and challenges of nursing practice in the rural Deep South, as well as to prepare them for caring for people from rural areas, so getting to actually see what some of those rural social determinants of health are, so that they can provide sound care transitions for when that person goes back to their community after seeking care somewhere outside of their rural community. There are some significant rural health challenges in the Deep South that include health disparities, problems with care access, and difficulties with care transitions. The rural South leads in mortality rates for the top 10 causes of death in the United States. There is less access to reliable information technology. Cellular phone service is spotty. Internet isn't always available. And those are ways in which people now access health information, make appointments with their providers. And so our rural communities are at a disadvantage for that. People in the rural areas are less likely to engage in positive health behaviors, and there are limited public services to promote health and to encourage those positive health behaviors. We have unequal healthcare workforce distribution, and that means our health services are impacted by that, our ability to provide care to the population. Our rural populations often have to travel long distances to obtain care. An example here in Alabama is that it is not uncommon for a woman in her pregnancy to have to travel by car an hour and a half or more to the nearest health facility that has obstetrical service. So we have a distinct lack of that. And since our residents often are lower income residents, they may not have reliable transportation to care. In the United States, employers are not required to provide employer subsidized insurance unless the business has 50 full-time employees or more. In the rural Deep South, most businesses are small, and therefore employer-provided health care is a nice thing to have, but not everybody has that. And so we have higher rates of underinsured individuals than the rest of the country. And since many of our residents have to obtain care in suburban or urban areas, they are often given health recommendations by the practitioners in those areas that aren't feasible for those who live in the rural South. And there also are fewer in-home health services available, like in-home physical therapy or home health care, making transition home difficult. Now, our initiative was aimed at addressing 3 of these challenges. The students are encouraged to help residents learn about and engage in positive health behaviors. So health promotion is part of the things that we are hoping that they will learn. We also would like them to consider practicing in rural areas once they have graduated and address some of that unequal healthcare workforce distribution. And again, getting to really see what the community is all about. And so that even if they never return to a rural area to practice, they have an understanding of what is feasible when you are advising people who are going home after being cared for in other areas. So what was our process? First, we had to design and plan the practicum, and it is housed within a greater community health, public health course. So we didn't create its own course. It is a clinical rotation housed within a community health and public health course. But we had to create that clinical practicum focused on nursing practice within the rural South. And in order to implement it, we needed to build partnerships with community agencies in those rural areas. And then we had to determine a way to evaluate our efficacy when it comes to the impact of this rotation on our students, on our community partners, and on the workforce as a whole. So when it came to designing and planning, we had 5 primary priorities: identifying learning objectives that are specific to this clinical rotation, selecting a way to structure the rotation to have some type of framework for it, so selecting a conceptual framework. We knew it was going to cost some money because students a fair distance away from the urban school that they are attending, which is the University of Alabama at Birmingham, out into rural Alabama, so about 100 miles from where they're actually going to school. So they do a 180-mile round trip when they do this clinical rotation, and that's going to cost a little bit of money. So we needed our leadership to be on board with that. We needed to have a plan for how we were going to develop those community partnerships. And then we had to be very thoughtful about which students should we assign to this experience for us to meet some of those goals in terms of workforce development. So one of the things that was of concern to us when we were identifying learning objectives is we knew that they had to align with the university's and the School of Nursing's primary mission. Fortunately, the School of Nursing, as well as the university as a whole, has a strong commitment to our first-generation students from underrepresented racial or ethnic groups, as well as providing service to underserved communities. So developing a rural-focused nursing practicum really aligns very well with that. So we didn't have any problems with that. We also wanted to be sure that the practicum's objectives aligned well with the course's objectives, and they actually do. And what you see here is basically the course objectives, but they have a rural health spin to them. So the focus is on promoting change in rural settings. The students have an opportunity to assess community needs and to make some evidence-based recommendations for improvement. They get to see how some of the lifestyle and cultural influences of living in the Deep South impact health behaviors and practices. They get to see how nursing care coordination occurs there, the different types of public policies that impact health in rural areas. And finally, as they develop their own professional identity, we're hoping that they actually will seriously consider practicing in rural areas once they have a license to do so. When it came to structuring the experience, we chose the social determinants of health, and we took a week. Every week, we focus on a different social determinant of health. It provided us with a good structure for making sure that the students really experience a well-rounded viewpoint of what it's like to live in the rural Deep South. Now, I mentioned that buy-in from leadership, and one of our greatest challenges was how do we move 10 students plus faculty almost 100 miles from campus and back in a single day. And we were fortunate in that the School of Nursing owns a large SUV, and so faculty drive that SUV with 6 other students in it. And then we have 1 student volunteer who takes the rest of the student group. And gasoline is paid for. And in some countries, petrol is very expensive. Here in the United States, it's a little more affordable, but still expensive for students. So we offset that, and the dean's office does pay for the students' gas for that. Other expenses that they may incur, like eating out in public with, buying lunch, etc., that's on the student, but getting there and back is not. So then we had to come up with who will be our community partners, and these were developed over time. We started out actually with Project Horseshoe Farm, which is a community health organization run by a psychiatrist who has professional associates everywhere, and really helped us get to know others in the community, and really helped us identify other people who would collaborate with us. But we tried very hard to identify healthcare organizations, cultural organizations, local employers, schools, so that the students had a wide variety of who they are going to be involved with. So this is a breakdown of who our partners are for each week. And so on the week when the focus is on healthcare access and quality, and that's every morning, they get that every week actually, they are either spending time in Hale County Hospital or in a home health organization, or they work with the emergency medical services. They may also be holding a health clinic at Project Horseshoe Farm. And so their mornings are spent doing that. The social community context, they get an opportunity to meet a local judge who talks about the different laws that impact the area, how his decisions as a judge impacts the health and well-being of families. They get an understanding of what the history is of the area through the Safe House Black History Museum. They actually get to walk through some of the historic cemeteries. And as I mentioned in the past, our part of the country has a legacy of enslaved Americans, as well as even after those enslaved Americans gained freedom, it was an apartheid system up until basically when the civil rights movement in the 1960s helped break down that system. And so a lot of the social context remains. We still have a lot of health disparities due to that. They get an opportunity to go to a catfish farm, which is one of the primary economic engines for the area. They get to determine what food sources are, so they get to see firsthand that this is a food desert for many people. They have a wonderful opportunity when it comes to neighborhood and built environment of collaborating with Auburn University has an architecture school that focuses on building affordable houses for rural residents, as well as building civic buildings as well, like firehouses, libraries. And so they get an opportunity to talk with those architects and architecture students about what makes a healthy home, physically, what makes a healthy built environment. And they do spend some time meeting the children in the after-school programs. They meet the community librarians. As I mentioned, the community librarians are often the source for things like internet and assistance in obtaining health information. And so I'm going to turn this over to Erica. Erica, you're on to talk about how we chose the students for this experience.
Perfect. Thank you, Dr. Crooks. So as co-coordinator for this community health clinical course in which this rural health experience lives, I've helped to institute a process for all of the pre-licensure students enrolled to self-select a community health clinical site from a descriptive written and visual menu of options. And this unique rural health experience in Hale County is included as an option on this menu and includes critical details of the experience for a student to consider when they're thinking about choosing this as a clinical rotation. So for instance, the menu provides information about the commute time to the clinical sites in Hale County, which is a 3 to 4 hour down and back travel time required weekly. And it describes the diversity of rural health clinical practice placements that the students will encounter in this experience. Next slide, please. So through the years of implementing this rural health clinical experience, there's been a diversity of student selection processes that have been used. There's been random assignment, self-selection, and also students that were assigned to this rotation through being in a special honor section in the course. So the least successful of these assignment methods was the random assignment because these randomly assigned students didn't demonstrate the desire to commit to this unique experience. And then specifically assigning honor students to this experience worked well because these students were inherently had a commitment to excellence in their work. And but limiting this experience to only honor students didn't foster their autonomy in selecting a community health clinical experience, and it didn't expand the option for this unique experience to all eligible students. So what's in place currently, the self-selection process, is proving to be a selection procedure that really recruits motivated and engaged students.
So now let's talk about implementation. We've got planning out of the way. We wanted to make sure that the experience is aligned with the learning objectives, that the students were active participants and not just passive observers. And we wanted to make sure that we would continue to foster collaborative relationships with our community partners as faculty. So this is what a standard day looks like. We actually pull away from the School of Nursing at 6 o'clock in the morning, arriving around 8 o'clock in the morning in Hale County. The students spend time then in the medical, basically healthcare organization focused experiences. We eat together around noon out in the community where they practice observational skills, looking at the 3 Ps: people, places, products, and services. And then in the afternoon, we have the social determinant of health focused activities with a debrief and a report out so that everyone can share what they did at their various experiences that day with one another. And then we head back to Birmingham around 4 o'clock in the afternoon, arriving back at 6 p.m. So it's a long 12-hour day for them with about 4 hours of travel time. And I mentioned that we really want these students to be actively engaged, and they are. If they are in the hospital environment, if it's something that a nurse is capable of doing, then they're permitted to do it. When they're at the EMS, they will run on calls with the EMS folks. And so it is a lot of activity for them, and there isn't much time for them to just be passive. We actually get them engaged. We also work very hard to maintain our collaborative relationships within the community, and there are some keys to success for that. You have to have a heart for rural life, and so our faculty obviously do. When we're looking at how will this new partner work with us, we have to figure out, well, where do they fit with those social determinants? We go down even into the community, even when we don't have students with us, to maintain our connections to the community. We'll often ask for referrals, and we'll talk to anybody. But that's actually a cultural thing in the Deep South. We talk to anybody. We ask all kinds of questions of people. But we also want to make sure that we return something to that community for the time that they give us. So evaluation can be pretty complex. We're looking at the students, we're looking at our community partners, and we try to make some data-supported changes when we need to. And we have both developmental and summative feedback from our students. And what I'm going to share with you here is the summative feedback from 2023 and our most recent 2024 data on a scale of 1 to 5. The course consistently scores 4.4 to 4.8 out of 5. That's really high. And then when we do thematic analysis of our qualitative data, the students really feel like they're making some meaningful contributions. They feel fulfilled by their experience down there. One of the things that they find that they were able to practice doing was to have, casual conversations with people, something that I believe the pandemic may have gotten in the way of their developing that skill. They're very surprised at how wide the nurse's knowledge has to be when they practice in the area. And the one thing that I'd really like to point out is that while several of our students have said they intend to practice in rural areas, they only are willing to do that after gaining experience in suburban and urban hospitals. So they aren't interested in coming right back. And that's something to think about. So in terms of limitations, that sample size was small. It was only an N of 40. We don't yet have data on the number of students who follow through on their intent to practice in rural communities. This program has been in place for about 7 years. And so that's our next step. Our next step is to really, survey those graduates from 2020 and on. Even before 2020, I started doing this in 2016. They didn't see as much, but I certainly could ask them. And then, this idea that they don't feel ready to practice, to explore the feasibility of establishing a nurse residency so that these new graduates don't feel that they have to practice somewhere else before coming, because we know very often if you practice somewhere else, you'll settle in and you'll never come back. And so that's one of the things that we are looking at, is the feasibility of possibly developing rural nurse residencies. And so here we go. I think we have 1 minute for questions, Stacy.
No, you are perfectly fine. That was so incredible. Thank you for sharing all of that valuable information. We do have a couple minutes for some questions if anyone would like to ask something before we move to our second presentation. Zao from Malawi asks, how best should it be done so that rural nurses are maintained in Alabama, citing that less payment is one of the factors nurses don't practice in the community?
I love that question, because that really is one of the things that we have to, it's one of the primary barriers. Now, there are a few ways to manage that, but probably the one that would be most successful is through policy formation, where those who are willing to practice in underserved areas end up with loan forgiveness for their education, who end up with tax credits for being willing to practice in underserved areas. These are all common ways in other states in which having their underserved areas be more attractive to nursing. The other thing is that there are some communities that are considering things like supporting a nurse through their education with them paying back by practicing in the area. So they pay for your education, but you are bound to them for a period of time as sort of a payback. But you earn money, you're not enslaved, but you do get, you do have an obligation, of course, to pay back. Erica, is there anything you wanted to add to that other than the policy issues?
No, that was on the front of my mind, was loan forgiveness programs and policy to support that. So
yeah, our critical access hospitals are compensated at a higher rate when it comes to Medicare and Medicaid, but that doesn't translate into more money for clinicians. It helps just to offset the fact that they're low volume hospitals, and so that isn't something that would work. But the rest of it would be really communities who want to make some rational policies that would attract all types of clinicians, nurses, physicians, to underserved areas. Thank you so much for asking that question.
Thank you. Any other questions today? Okay. I just would like to remind everyone that in the event that you do have a question that pops up after the fact, feel free to go ahead and just shoot us an email. I'm going to type it into the chat, but you can reach us at info@grnen.org. And we will make sure to push your conversation along to the appropriate party. As always, we thank you very much for including us on your calendar today, taking the time out of your incredibly busy schedules to join us. Thank you to our presenters as well. We are so appreciative that you are willing to share your important research with our community. And we wish everyone a wonderful rest of your evening or your day, wherever you may be dialing in from. And thank you very much.